For those of you who I haven't met yet, I'm Dr. Escott. I'm your new medical director. I've been here about 100 days, more or less-ish. So I'm going to talk today about a vision, okay? This is a 20-year vision, give or take, all right? So don't freak out. Don't go back to administration and say, Escott's going to do this tomorrow, because this is going to take time, okay? I'll explain more. I'll give you a brief history of myself in about 90 seconds. I started as an EMT in 1991 at Cypress Creek EMS outside of Houston. You guys know Cypress Creek? Red shirts. So I started as an EMT there, firefighter with Champions Fire Department in Spring. Went through, became an intermediate paramedic, started EMS service at Rice University 20 years ago. Was on faculty there for 2 years while I was doing my Master's of Public Health at the University of Texas. Medical school, 99, I went to Australia, Flinders University in Adelaide, Austin's sister city. Did an internship at the University of Adelaide, residency at Penn State, chief resident at Penn State, associate medical director for Penn State Lifeline EMS, medical director for EMS Special Operations, so SWAT, special events, etc. Was there 2 years, then got recruited by Baylor College of Medicine 6 years ago, was the director of the Division of EMS and Disaster Medicine there, associate medical director for Cypress Creek EMS, medical director for Rice University, then became the medical director for Montgomery County Hospital District and the Public Health Authority for Montgomery County, and then I came here. That was about 90 seconds, right? That was close. Okay, that's my life in a nutshell. I have a wife, I have 2 kids, 11 and 13. I'm still recovering. My daughter went on her first date last Friday. The boy's recovering too. My wife said you can't scare away the good ones, Mark, and he's the good one, so.
You have please contact yourself and follow him the whole time secretly.
I can't give away the. Of course, I get phone calls in the middle. All right. So this is the new symbol of the Office of the Medical Director. You guys have seen it. But I want to talk about this. Okay, this is the Capitol. You guys know this. But what we've done here is merge the traditional symbol for EMS, the Star of Life, with the traditional symbol for physicians, the caduceus. Why? Because we intend this to be a conscious transition from a technician mindset in EMS medicine to a clinician mindset in EMS medicine. And that's what this lecture is about. Okay. Oopsie, I pressed too many. Okay. So how did we get to where we are today? If we're going to discuss our 20-year vision, we've got to discuss how we got to the point that we are today. So we're going to have a brief history lesson. Highway Safety Act of 66, EMS Service Development Act of 73. This is where we came from. Okay? Why do I have this picture here? Wait, what? Maybe you should come up in front of the camera and say that again. Mother, drugs, and speed?
Mother, drugs, and speed.
Got it.
You've never seen.
Oh my God!
I feel like I've.
Points there. You can watch it.
I'll let you borrow that.
Okay. Got. I may have a tape player somewhere. So, where's our young? What is this here? A hearse. Why is it a hearse?
That's what we use to transport.
Yes. Okay. So, one of the medics that trained me, his name's Dodd Lang. He's a paramedic from Brenham, Texas, country boy. His family had a funeral home service, and when he was a boy, and by boy I mean a child, he'd go out on calls with his dad, and his dad would send him out in the ditch and say, "Dodd, go see if he's alive or dead." If they were alive, they went to the hospital. They're dead, they didn't. But there was nothing else that happened in the back of that ambulance on the way to the hospital. In fact, this is the way a lot of EMS still is today. I told the other groups I went on a trip to West Africa during Ebola outbreak with a group from Baylor College of Medicine, and ambulances in West Africa have a dude with a shirt and a tie who drives the ambulance. puts the patient in the back, he gets in the front, and that's the extent of what happens. Okay? But it's changed a lot here in the United States and other parts of the Western world because we decided that we're going to train people to do stuff, right? And in the ensuing 40 years, we've done a lot of research associated with what we do in the back of the ambulance, what we do in the field. Okay? Primarily, those research studies, and there's been a lot of research in a lot of different areas, but a lot of them has focused on these 4 things. Why these 4 things? That's a question, and you can answer.
Highest mortality rate.
Their life threats. What do they all have in common?
Quick intervention.
They're time-dependent emergencies, right? These are the things where seconds and minutes count. Okay, STEMI, stroke, cardiac arrest, trauma, and there are some other things. Okay, but not a lot of other things. This is what we build our EMS systems around. These things. Because of that body of research over the past 40 years, in 2011, the American Board of Medical Specialties decided EMS should be a subspecialty of medicine. Okay, did you guys know this? Raise your hand if you knew it. Okay, it's more than most other classes. Okay, so what does this mean for us? It means that EMS is now like cardiology or gastroenterology or neurology. It is a medical practice. Okay, but what does it mean for you? Okay. I'm going to get to that. This is a picture of the first group of EMS board certified docs. This is 2014. We had 240 then. That's me there. Now in the United States we have about 500 nationwide. Okay. So the big deal is that it really changes the way we view EMS providers, paramedics, from what used to be a technician to now a physician extender. Okay, what do I mean by physician extender? Okay. So, yeah, what are the other ones? We have PAs, nurse practitioners, and other, there's lots of different names, but nurse anesthetists, people who are not doctors, who are working under doctors and are practicing medicine. Okay. When EMS changed to a medical subspecialty and not just a public service, it changes the definition of our medics. All right? By definition, you are now physician extenders. The problem is that we don't look like the rest of physician extenders. Okay? So, education-wise, associate's degree, maybe, for our top end. Or nurse practitioners. Generally speaking, who are they seeing in the ER? If you've seen a PA or a nurse practitioner in the ER, are they in the trauma bay? Are they working the cardiac arrest? Who are they seeing? They're seeing fast track. Generally the ESI 4s and 5s, the low acuity stuff. Okay? What patients are we seeing? We see those people also, but we also see the most critical people in the ditch in the middle of Page, Texas was mine last week, middle of nowhere with limited resources. Okay, there's a difference. What about oversight? Okay, if I'm a PA working in an ER and I'm having trouble with the patient, or I don't know what to do, or I need an extra set of hands, what do I do?
Turn to the guy sitting next to you.
Yeah.
He's the physician.
Yeah, you go grab the doc or one of the other 5 docs that's working with you, and you have direct physician oversight. What about legislation-wise? Okay, how many physician assistants or physician extenders can I delegate my practice to? 6. Okay, normal span of control measures. What about EMS? It's unlimited. Well, it's not unlimited technically speaking. Okay, I as an individual physician can only have 20 EMS services under my license. All right, so I could add on Houston and Dallas and San Antonio and El Paso and Amarillo, and I'd still be okay, legally speaking. But there is no limit. Okay? So there are limits in some states, or there's limits in one state, I should say, the very progressive state of New York, which says that for every 100 ALS providers, you need a full-time doctor, and for every 500 BLS, you need a full-time doctor. So if this system were in the state of New York, we would need 8 or 9 physicians to oversee this practice. But there's a difference, okay? And the big difference is this. All right, $40,000 is the average starting salary for a paramedic in the United States. $100,000 is the average for a PA. Why do you think that is? right? This is the commodity that people determine what people should make. Generally, unless you're talking about business, and then it's different. But generally speaking, for professions, it's this, okay? So we're going to talk about why that's a problem for us, all right? So how are we going to bridge the gap, right? I talked about this being a 20-year process. What can we do now that's going to make a difference in how we're perceived, all right? First of all, we have to have greater expectations for ourselves, for how we measure what we do and how we measure quality, okay? Traditionally speaking, when I was a medic, well, I still am a medic, but when I was working as a medic, this was the most important things right here. Did you clean your ambulance? Did you clean your station? Are the toilets clean? Is the truck stocked? How fast are you getting out of the station? How fast do you turn around at the hospital? These are things which operationally are important, right? We are a clinical operation and a mobile operation, so we've got to make sure that we're mobile and that we do those things. You can't have hospitals where it's just the clinical providers and not the operations folks which are involved in the running of the hospital. So both are important. Okay. My favorite measure of technician quality is these response times. Okay. Now, what do you know about response times? What's the evidence about the importance of response times? When are they important? They are important. For time-sensitive issues, right? What are those? STEMI, stroke, cardiac arrest, trauma, and then the other things, right? Airway stuff, sure. If they make an auto-injector for it, it's another time-dependent emergency. But how much does that represent of what we do? It's 5-10%, generally speaking. I don't know the numbers here. I know wherever you go, cardiac arrest represents 1% of the call volume of wherever. Okay, so it's small. Okay, so why don't we focus on response times? We have data. It's easy to measure. Okay, but where did our burden of response times come from? But
Mostly what you did.
from the NFPA, okay, from fire. Okay, again, when you're measuring quality of a system, it's more difficult to measure what you actually do and the quality of what you do and the impact of that versus how fast I get there. And so the public has this in mind, right? When we do that, it gives them a butts in seats mentality. Okay? So if we focus on response times, it doesn't matter who's in the seat. The quality of the care doesn't matter. What matters is how fast they get there. All right, which is not a great thinking to only focus on that when a very small percentage of our emergencies really make a difference how fast we get there. Okay? What about on the fire side? I got some fire folks here? No? No fire folks? Fire folks here? All right. So okay, but it's not it's not that different for fire, right? If you look at time-dependent emergencies in fire, what are you talking about? Structure fire, right? Maybe victims within, or the impact of delayed response means losing the house instead of losing the room. Okay, and you have rescues, and you may have a few other things where lives are at risk or significant infrastructure is at risk, right? In the Austin Fire Department, what percentage of calls does that represent? 1%. 1%. 0.7 on structure fire, 0.3 on rescues. That may be reversed. It's reversed. 0.3 structure, 0.7 rescue. It's a small number. Okay, but again, we still focus on that response time. So we need to focus on response times when response times are important. We need to focus on other things when other things are important. Now, we've tried to measure clinical quality before, and these were the measures when I was growing up, right? The big ones were IV success and intubation success rates, right? These are critically important. Now, you're a provider, you're charged with doing critical skills. It's sort of important that you can do these things when you need to. But what do you know about the self-reporting of success rates? Yeah, you sort of learn to record things in a way that makes your success rate's good. Okay? Sometimes it's intentional, sometimes it's not. I'll give you an example on the doctor's side, right? There was a recent study on pediatric intubation, first pass success rate. And doctors reported, I think it was about 85% first pass success rate. When they looked at the video, it was like 54%. Okay? Sometimes you forget those attempts that don't work, intentionally or unintentionally. Okay? We have things like chest compression fracture now. And my favorite measure of clinical quality has been this adherence to protocols, right? So generally speaking, when you talk about chart review in EMS services, it involves this. What protocol did you select, and what did your chart look like? And then you compare the two. If they match, you did well. If they don't match, you get in trouble. Why? Because we've told you that you can't diagnose, right? We use this Jedi mind trick on you over the past 40 years to say, you're only technicians, and you recognize patterns, and you follow the prescribed course for that pattern that you recognize. Now, I don't really understand that, because if you see somebody that's in cardiac arrest and they've got a squiggly line on the monitor and you put pads on and you shock them, that seems like a diagnosis to me and a treat. It's a little goofy. Okay? They really went extreme on this when I was a medic. Some of you probably remember this. If you had somebody with an arm that was at a 90-degree angle, you could not call it a fracture, right? Because you can't diagnose. All right, so what did we have to call it? No, it's not even a suspected fracture, because that's kind of like a diagnosis.
Arm injury.
It was a painful swollen deformity. All right, it's stupid, right? There's no other option than a fracture. But again, we wanted to really hammer hard on this. You can't diagnose business. But that's a problem, because we've taught you not to think. We've taught you to look for patterns, to recognize patterns, and follow the guide. Okay? But what we actually need in EMS is we need clinical masters. Okay? We don't need pattern recognizers. We need clinicians. And we're going to talk about how we're going to get there. So I got there via Qantas, I told you. I went to, this is the Australian airline for those of you who don't know. Okay? So let's talk about the Australian model. Step 1, bachelor's degree. Okay? They have ambulance studies, bachelor's degree, Bachelor of Health Sciences and paramedic study. There's lots of different names for it. But requirement number 1 is bachelor's degree. There's a paramedic internship. Okay? This is the South Australian model, 16 months. Ambulance Service Victoria, the Victorian Ambulance Service, just posted their new program, which is a 2-year internship program. Okay, 2 years. So not red patch and then out the door, or red patch out the door after 16 weeks. 2 years.
Are they paying their intern?
Yes. Now, that doesn't mean you can go to Australia and leave us. Okay. After that, they can apply for a permanent position, and then once they have a permanent position, then they can do this other training. All right, intensive care paramedic, extended care, which is like community paramedic, or rescue, or special operations. Okay, now, what does this look like to you? This bachelor's plus 16 months or 2 years. What's that? PA. Looks like a PA training, right? Mm-hmm. And guess what? The result for paramedics in Australia has been this. Okay. So what's happened over and this is a 20-year project, folks. Okay, 20 years it took to do this. And why did they do it? They did it because they realized that, and when they compared themselves to nurses, we work in different environments which are more complicated. We have to diagnose, we have to treat, and we have a lot of responsibility. And we have trouble recruiting people into this field that are qualified and that want to stay in it. Okay, so we've got to change things. And we're going to change things by starting with the education piece. Okay? This wasn't the Australian government. This wasn't the EMS doctor saying you have to do this. This was the workforce saying we want more. We want more, and this is what we're willing to do to get it. Okay? This is how it changed. Now, were they the first ones to have this great thought that they need to formalize their education process and increase their pay and respect? No.
Nurses thought of it.
Nurses did it in the 1950s, okay, because they had the same problem. We have a brain drain in EMS, okay? What do I mean by brain drain? I'll give you an example, Okay, I went to the BLS Academy, gave my little medical director talk, and then I said, let me ask you this question, folks. How many of you are interested in going to nursing school? Half of the class raised their hands. Half of the class is interested in doing something else. Okay, this is a problem for us. All right, the problem is that we get people in, we train them, we educate them, they go off and get a bachelor's or master's or whatever, and then they leave us. Okay? We have this drain of expertise that happens in EMS, which is why we have an imperfect system right now. We've got to fix that. We need to keep people with experience and education because there's a huge investment in that, because it's hard to train the people coming in if all the experts are leaving. Okay? So, we're not going to pay you this right now, but again, you understand the importance of having a collective mission to move forward if we're going to get there. Okay? So, what can we change now? Well, first of all, we're going to break you out of this protocol jail. Okay? So, what do I mean by that? Well, let's give you an example of why it's important. So, this is a case that I published in one of my GEMS columns. And this is a 60-year-old female. It may have actually been a male. I don't know. But anyway, that's not the point. Heart rate was 48. The field training officer with 10 years of experience said, this is symptomatic bradycardia. I'm going to pace the person. Okay. Protocol selected. Symptomatic bradycardia. Chart. Something which is grossly appropriate for symptomatic bradycardia. Went through the QI process. What do you think it said? It said good job, right? Because we're just doing a matchy-matchy. Okay? And the problem is, this is the rest of the case. Okay? The blood pressure was 240 over 150. Okay? Now, why does this happen? There's a couple reasons. All right? First of all, you have to understand the pathophysiology of symptomatic bradycardia to understand that this pattern doesn't fit. Right? Why do people become symptomatic from bradycardia?
Hypotension.
Because of, more specifically, hypoperfusion. Okay? Hypoperfusion. Who thinks this person has hypoperfusion? Yeah, nobody, really? Okay? Yeah, so that's problem number one. Problem number two is this. What we've done over the past 40 years is we've trained you to be pattern recognizers. Okay? We've trained you in heuristics. All right? These are the patterns out there. Look for a pattern. When you find a pattern, hold on to it and follow it. Okay? We're going to reinforce that message by doing this matchy-matchy business. Okay? Because all we care about is whether your chart looks like the protocol. Okay? So, and we see this over and over again with lots of different kind of cases, right? And you guys have probably seen it amongst your peers at times throughout the years. You see people who are very good when the case is straightforward and who really struggle when there could be more than one thing that's going on. Okay? Why is that? Because we traditionally haven't taught you about differential diagnoses. Okay? So what do I mean by differential diagnoses? I know you guys have had training in this. What does that mean? You got to consider all the possibilities. From the moment you're dispatched on the call, you've got to start thinking, could be this, could be this, could be this. You get some more pre-arrival instructions, you refine that. You get on scene, you see the patient, you refine it. You get a history, you refine it. You do a physical examination, you refine it more. You attach your monitor, you do end-tidal CO2, you put your pulse oximeter on, you get a glucose, you continually refine it. Okay? You tailor your questions in your physical examination based upon your differential diagnoses. And then you have to sort of triage what's the most likely and what's the least likely, and then intentionally follow the path which you think is most likely. Does that mean you're going to be on the right path? Maybe not. Okay, maybe not. The sign of a good seasoned clinician is to get off that path they're on and to get on the right path when they see the evidence that shows they should be on a different path. But unless we start doing this every day, we're not going to refine our clinical knowledge. We're not going to refine our clinical decision making. And this is absolutely critical to getting to where we need to be. This means practically every day on the ambulance, you should be having this discussion. Medic 2s to Medic 1s, commanders to Medic 2s and captains. You got to have this dialogue. This is not threatening. This is the way the rest of medicine does it. Okay? If you have spent any time in the ER or in any training program, academic practice, this is what happens. An intern presents to me, a resident presents to me, a PA or presents to me. I'm going to ask them this question: what's your differential diagnosis? And they're going to list it for me. Okay? We have to do this, folks. Okay? So we also have to embrace the things that the rest of medicine does. Okay? I talked about before about this being a medical subspecialty now. And really, we used to be in the sort of front yard of the house of medicine. Okay? Now we're up on the front porch. If we want to go inside and live comfortably, we've got to start modeling our practice the way the rest of medicine does. All right? And this is going to be a theme for the rest of the talk here. So how do we do that for our interns and our residents? And even our faculty? We have things like self-directed learning objectives. Okay? What do I mean by that? What's a self-directed learning objective? That's a question. You can, anytime.
After the call, you look stuff up.
Yeah, you say, well, you know what? I didn't know what that drug was. I'm going to look it up. Okay? This doctor said this patient had a diagnosis of XYZ. I had no idea what that was. Or I went on OB call and I was freaking out because I didn't remember what to do for a breech birth. So I decided to go in at that moment and look it up. Okay? This is a way that we initiate that lifelong self-learning for our interns and our residents and our faculty. By modeling this, it creates a habit of you self-improving. Okay, why is that? Well, you got to realize that, traditionally in EMS, the workforce feels that the institution will give to the medics what you need to improve. Okay, now that's true. We're going to give you some stuff, but you got to remember we have 2,000 providers in this system, and we cannot have 2,000 different education programs for the institution. You have to decide what your gaps are and how you can fill them, and this is okay. You have to find out what happens to patients. Okay. Now we're going to have electronic methods for doing that, and we do that now. But guess what? You can get the phone number of the person. You can call them and say, "Hey, this is paramedic so-and-so from Ostraves County EMS, checking in on you today. I took care of you last week. Want to see how you're doing. What's your diagnosis? How long were you in the hospital? Did you go in the ICU? Did you get a cath?" All those sorts of questions. Okay? Why is that important? There's a couple of reasons. First of all, the patients love it. Right? You called, you care, everybody feels happy about that. You engage the community, they think it's wonderful. Okay? Number two, you get to refine your diagnostic skills. Right? It's really, really hard to become a better diagnostician when you have no idea what the actual diagnosis was. Okay? This is critically important. All right? And it doesn't have to rely on electronics to do it. It can rely on picking up the phone. Okay? We require this for our residents. Right? You want to pass from year 1 to year 2, you got to have a certain number of patient callbacks. You have to have a certain number of self-directed learning objectives. It's up to you to manage your practice. All right? We do this in some of the hospitals I work in. You have to call back 10% of the patients you see and see how they do. Again, why? Because they love it and it helps you refine your diagnostic abilities. There are other things like quality improvement initiatives, right? You discover in your own practice ways to improve. You create a plan to do that and you implement it. M&M says we'll talk about in a minute. And then evaluation of your performance compared to other people's. Okay, now, it's hard to know how to improve if you don't know how you're doing, right? So we've got a few clinical measures now that we collect data on that you have access to, but the intention is to provide a broader scope of areas so that you can constantly be able to go in, look at your personal dashboard, and see how you're doing compared to your peers, so that you know if your charts are not as good as the benchmark, or you're not as good as at assessing glucose and potential CVAs, or whatever that measure is. You can go in and self-assess and have your own initiative to improve. This is the practice of medicine. You guys want to practice medicine. I want you to practice medicine. This is how you get there. Okay? You take ownership of your practice. You take ownership of your quality improvement, and you self-direct where you need to be. We also can get there by doing better at understanding why. Okay? It's not good enough to memorize the protocols or memorize the guidelines. You have to understand why the guidelines are the way they are. Okay? So part of that is doing things like journal club. All right, what's a journal club? This is a journal club that we did in the Houston area for multiple different EMS services. But what do I mean when we talk about journal club? We had one last night with a few folks. What's a journal club? Anybody?
Bring journals, articles to the table, and determine how that affects
Yeah.
guidelines and practice.
Yeah, so you take new evidence, emerging evidence in the EMS and emergency medicine literature, you review them in a thoughtful process, you discuss them, and then you determine whether or not it's significant enough to change the clinical practice. Okay? And this is something we do together so that we self-discover the new evidence that's out there, we cognitively review it and make decisions on whether or not we should make some changes based upon it. All right? The understanding why also means knowing why your protocols, your guidelines are the way they are. All right? And what we're doing is when you see new guidelines come out, there will be references associated with those. So you know that this is the body of evidence that we made the decisions that resulted in this clinical guideline. Okay? Hold on just a second. Pause. I got to get a tissue. I forgot my tissue. Nope, this is good. Sorry about that. So hopefully at some stage, not only will you have the references for all the clinical guidelines, the reference page, but you also be able to hyperlink and pull up the full text of the article so that you can review it yourself. Why is this important? Well, the guidelines are guidelines, okay? It's the structure on which you build your clinical practice. If you look at things like permissive hypotension, it's really hard to write a clinical guideline that addresses all the possibilities in permissive hypotension, right? You know that you can use permissive hypotension for chest abdominal trauma, but it's contraindicated in head trauma. All right, so, Dr. Escott, what do we do if we've got a person and they've got a possible head injury because they're altered a little bit, but they've got a lot of chest injury and I'm not sure what to do? Well, you got to understand the evidence. You got to understand the evidence of why it's indicated in one and contraindicated the other, and make a decision based upon the patient in front of you. Okay, it's really critical that you have a more complete base for your education than just the clinical guidelines. Memorization of the guidelines is a start. It's not the end of developing the clinical practice. Okay. We also have to be objective about how we assess what we do. Okay. So what we're going to be doing is every time we review a chart, if that's the OMD, the DMOs, the FMOs, the FTOs, or whatever other initials are out there, they're going to assign a score, okay? A standard of care index and a documentation index. All right. Now these particular descriptions may change a little bit, but basically standard of care is, again, different from the matchy-matchy business, and it's actually assessing the chart and the treatment that the patient was provided and comparing it to the standard of care, not the protocol. Okay? So 5 is, superstar. This is what Dr. Escott would have done for this patient if he were standing here. 3 is you did okay, but not super. 1 is this is in no way representative of the standard of care. You were not only on the wrong page, you were in the wrong book. Okay? Generally speaking. Documentation. 5 is you can take this chart to court today. You don't need any further explanation. It's perfect. 3 is, yeah, it's okay. 1 is this really doesn't even meet the requirements of being a medical record. Okay? That's the idea. Okay? Now, did Dr. Escott make this up himself? No. Where did I get this? From the hospital, right? This is peer review scoring of hospital records. Okay? This is what the rest of medicine does. This is what we have to do if we want to live in that house of medicine. Okay? This is the expectation. So we will score charts. We'll see how we're doing as a system. We'll create benchmarks, and then you'll be able to compare yourself to how the rest of your peers are doing so that you can look for opportunities to self-improve. Okay? We also have to learn from our mistakes. This is the M&M session I was talking about. All right, what do I mean by M&M session?
Mortality, morbidity.
Morbidity and mortality, that's right. Okay? We have to identify opportunities to improve. Okay? We are not perfect. I don't expect for you to be perfect. I expect for you to want to be perfect. And there's a difference. Okay? The difference is the motivation to be honest and open about where we're not doing well and the desire to improve. Okay? It's acceptable to me and to other people when you make mistakes. I get that. We're going to make mistakes. We got tough decisions. We face difficult situations because we're placed in the arena to take care of people who are critically ill. What's not acceptable is not to be open and honest about when we don't do things right and continue to make the mistake again and again and again. Okay? So this was a session that we did with at BRAC with trauma surgery, emergency medicine, and us. All right, we had a procedure that didn't go perfectly. It was successful, but it wasn't perfect. Emergency medicine at BRAC had a procedure that didn't go well, and we had open discussion about the procedure, the physiology, the pathophysiology, the common pitfalls, and we all left there in a respectful way and learned from the discussion. This is what we do. We can do it in an open and honest and respectful way without being critical, overly critical. Okay? We've got to be somewhat critical if we're going to improve, but we don't have to be overly critical. Okay? There's a little music going on there. Okay? So we also have to celebrate our victories if we're going to really champion this idea of the EMS clinician or the paramedic practitioner. So we developed this Medical Director's Clinical Excellence Award. All right? This is awarded to individual people. Now, I've got an example of it here, if I can get in my pocket. Okay. Now, it's not to scale, obviously. This is, I promise you a dinner plate, but this is what you get. It's a little challenge coin. It says awarded for clinical excellence. All right, it's the medical director badge. We understand that the team is important. We're going to recognize the team. The team gets the regular medical director challenge coin. Okay. This is awesome. This is awesomer. Okay. So these are numbered 001 to 101. There's only 100 of them. All right, and there'll be a big plaque in the medical director's office that has all the lists of the names of people who are awarded them. Okay. We're taking nominations from the field, from docs, from the public, whoever. All right, we're looking for excellence in clinical decision making for individuals. Okay. Now, we've given away number 001. You guys know Selena? Yeah? Okay. I'm going to read the award and then the nomination. The Medical Directors, this is November 7th, 2016, the Medical Directors Clinical Excellence Award was created to recognize exceptional performance by a system provider in their duties within the City of Austin, Travis County EMS system. While the care of our patients is a team effort, the award is intended to recognize team leaders or other individuals who have displayed excellence in clinical judgment and leadership in challenging situations. These individuals embody the principles of the EMS clinician and the values of the Austin Travis County EMS system. In recognition of the excellence in clinical decision making, leading to the rescue of 3 critically ill newborns, it is my pleasure to present the Medical Director's Clinical Excellence Award number 001 to Selena Shia. Okay. So case number 1, the providers below arrived on the scene of a newly born male who quickly deteriorated after delivery by a midwife. On arrival, the infant was receiving active CPR by the midwife. The providers quickly assessed, warmed, and stimulated the infant, who was persistently cyanotic, bradycardic, and in respiratory distress. Oxygen and BVM were started immediately. With the help of positive pressure ventilation, the infant began breathing spontaneously, and the heart rate increased. Medic 10 and AFD Engine 25 were all involved in patient care or logistics of expediting transport. Selena directed the entire scene in a poised and professional manner. All involved kept the call moving forward without appearing rushed or uncoordinated. Selena contacted the receiving hospital from the scene to make sure they were able and prepared to accept this patient. Medic 10 and firefighters from Engine 25 transported the patient together to provide ongoing support for the infant. On arrival, the infant had good color and strong pulse. The patient's father took the time to sincerely thank Selena on everything that was done and stated how impressed he was with the entire crew. That's baby number 1. Baby number 2 and 3. On this particular day, a call was received for a 36 weeks pregnant woman with twin gestation. Medcom Captain Stanford skillfully managed this patient after discovering her water had just broken and umbilical cord had prolapsed. Captain Stanford talked the caller through and her husband through the appropriate pre-arrival instructions, advised the mother to resist pushing, and kept her and her husband calm until EMS arrived. Upon arrival, the medical Evan team and AFC crew quickly recognized the severity of the situation, provided immediate life-saving care, and rapidly transported her to an appropriate perinatal center. Shortly after arrival, the patient underwent emergency C-section. The receiving physician explained to the patient's husband that, quote, "The paramedics saved your twins' lives and probably saved your wife's life also. We rarely see newborns survive a prolapsed cord. The fact that this was with twins and outside the hospital is nothing short of incredible. And the pre-hospital providers are responsible for them, your twins, and your wife being alive." That's number one. So, congratulations again to Selena. For those of you who have cases, please submit them to me. We'll review them and consider them for the subsequent awards. Okay? I don't want you holding your awards, and I know if I was in your seat, I would be doing it too. You might hold it on to think, I'm going to get 007, because I would totally want that. But please submit them so that we can recognize people who are doing well. Again, if we want to build the importance of the clinical mission and the importance of clinical decision making and the paramedic practitioner or EMS practitioner, we've got to start to recognize people who are doing this very well. Okay? Other business. We're going to talk about doctors. Okay? Now, we got three kind of doctors. EMS doctors. Yeah, thank you. One of the other classes said doctor. I'm like, yeah, it's not nice. ER doctor and
Specialist doctor.
intervener. Trouble. Okay? So, if you're on a call, and I bring this up because we had some confusion. If you're on a call and you need orders for something, which one of these do you call? You call the on-call EMS doctor. Okay? If you're transporting a patient to a hospital, you call the ER. Occasionally you may speak to a doctor, generally not. Okay? Now, if you're speaking to a doctor during transport and they say, yeah, you know, medic 20, we'll see you in 5 minutes, go ahead and give another bolus of fluid. You need to call me and say, hey, this doctor said we need to give fluid. Is it okay if we give fluid? All right. They can give orders, but the law now says at the moment they give you orders, they take responsibility for the patient, which is okay with me, but may not be okay with them. So keep in mind that that's the case with these guys, okay? And it has to be a doctor again. Nurse, tech, can't give you the orders, only a doc. Questions about that? What about intervener doctors? What does the law say about them?
Same thing. If they're giving orders, they're taking responsibility for the patient.
Okay. That's the way it used to be. Well, it sort of is now, but the law's changed about intervener doctors. The law says this. If a doctor on a scene wants to take control of the patient and give you direction, they have to call me and get permission. If I don't give them permission, then they can't take the patient. Why? Again, this is a medical practice now. You are my physician extenders, so other doctors who do not provide oversight over you cannot give you that direction unless they have my permission. Okay? Questions about that? Now, this doesn't mean if Dr. Zabel is on a scene and he wants to help and do stuff with you that you got to call me. And this is a card you can play if you need to. Okay? I don't know. I'm seeing 6th Street, doctor on scene, may or may not be impaired.
He's actually a dermatologist.
You've got the trump card. Okay? But, you know, if there's a critical situation and the person's qualified, don't feel like you have to call me. It's going to be a barrier. You need to do what's right for your patient. But know that the law says that they have to contact me to give you direction. Yep.
Is that the same role when you have to go to a clinic?
A clinic is different.
Urgent care, and they give us an order that they want us to do when we're in the hospital.
That you feel might be iffy.
They should contact me in that circumstance. Now, if it's their personal doctor and they are going to travel with the person, that's a different story if they're going to manage the patient and work outside of your clinical guidelines. But you know that's not going to happen. Okay? All right. You guys have heard about this part already? Yes. I've heard lots of grumbling. So, the clinical guidelines right now say that if a person has a medical problem or a potential medical problem, they're a patient. We and every EMS service that I've worked with have always had a problem interpreting what that means. Okay? So I choose to make it very simple. And the simple way I like to think about it is, if you are dispatched to assess an individual person, that is a patient. Okay? That means this dude over here, who may be sleeping or dead. That means this lift assist. That means this intoxicated person that's in custody. Those are all patients. Okay? There's two ways to disposition that patient. Patient refusal or transport to the hospital. That's it. Okay? Why is that the case? Because we see over and over and over again these people being dispositioned as a no patient. And that becomes a bit of a problem if we go back and something is wrong with him. Like he's dead this time, or they end up in critical care, or they end up dead in a jail cell. Okay? This is a problem everywhere I've been. This is a problem EMS nationwide. We got to fix it. And how do we fix it? I think we fix it the way we fix it in the rest of medicine. Right? If somebody comes up to my ER and wants to be checked out, or somebody brings them to my ER because they want them checked out, I have a legal burden. That legal burden is what? I have to provide a medical screening examination to that person to determine if there's a life threat or not. Okay, that's a patient. Now, if the patient says, well, screw you, I'm not staying here, I don't want to be checked out, I have to assess to make sure they're capable of refusing care. I have to offer them evaluation. I have to offer them vital signs. I have to offer them treatment. If they refuse, they can refuse. That's their business. But I have to offer it. It's the same thing with us. Again, if we want to be part of the house of medicine, we have to start having policies which are consistent with the rest of medicine. This is a policy which is consistent with the rest of medicine. Okay? If you get to this guy and he says, forget you, I was sleeping, I don't want to be seen. Sir, can I take your vital signs? No. Can I do a physical examination on you? No. Can I take you to the hospital? No. That's super. All right, you're done. Sign here. You don't want to sign here? Fine. Patient refused to sign. Here's the witness. You have to document something. You have to document that encounter. Okay? Same with lift assist, same with intoxicated people, same with everybody. This is not being called to a scene. If you're called to a scene by a third party of an MVA or a structure, apartment fire, I don't expect you to go around to everybody and get refusals on the 100 people that live there. Okay? But if somebody's been identified of concern, you have to make contact, and that ends with a transport or a refusal. All right? We've got some work to do on the administration side to make sure that the closed call rules are such that you don't have to collect, social security number and insurance information and allergies and past medical history on the dude who's sleeping. I don't need that, right? If he's decided that he doesn't want to be evaluated, I don't need that stuff. I need name, date of birth, and a little brief thing about what you did to offer, okay? And then the refusal signature. If he says, well, now that you mention it, I'd like my blood pressure checked, that's a different story. Yes, sir?
What about the guy that won't answer our A&O questions, so now we can't then
Well, that's a challenging situation, and you've got to make the assessment and decision. Or you phone a friend and you get help to make that decision. Let me give you an example from a different EMS service. I'm working at Ben Taub in Houston, it's the trauma center there, and I received this patient from the constable's office in handcuffs, and I say, officer, what's going on? Well, I tried to take this guy to jail, and the jail refused him, so they told me to get him checked out. I said, okay, what's going on? Well, we found him in the ditch along I-45, and the jail wouldn't take him because he's completely disoriented. Like, okay. So I take him to the trauma bay, put him in a C-collar, put him on a line, put him on the monitor, do a CAT scan of his head and neck, and labs and all kinds of stuff. And while that's going on, I'd say the officer, because I recognize him as working within the jurisdiction of one of my EMS services, I say, did you call EMS out? Yeah, EMS came out and they cleared him. All right. So I pull a chart. Well, it wasn't a chart because it was a no patient. So I call the team in and I slide that paper across the desk and say, hey, you remember this guy? And they lose color in their face. I'm like, yes, sir. What happened here? Oh, well, law enforcement called us out to check his blood sugar, and it was normal. So we dispositioned as no patient. Okay, well, that's not their version, right? Their version is you came and you saw them and you cleared them. Well, that's not what happened. Well, I don't have a chart. I mean, I just have call notes. So let me ask you this question. What's your differential diagnosis for a person found in a ditch along I-45 who is altered? Well, it could be CVA, it could be trauma, it could be overdose, it could be intox, it could be, and there's, a list of 20 things. I'm like, well, how did you sort that out? But that's not what they wanted. They wanted the blood sugar checked. I said, okay, let's take a step backwards. Why did they call you? You get called every time somebody gets pulled over? Well, no. Well, the guy was completely altered. Yes, that's why they called you. Okay? Remember, when you're the police, not to simplify the job, but your differential diagnosis for somebody in custody or who's altered is very narrow, right? They're either intoxicated or high or their blood sugar is low, right? There's nothing else. All right? So if somebody calls you and says, hey, I want a blood sugar check, you got to dig a little bit deeper because we're healthcare professionals. Okay? So, we have to be mindful of the fact that if somebody calls us for a lift assist, to them they may just need help getting in the car or getting in the bed, but we're the healthcare professionals. We have to think deeper. Why can't this person get up like they could yesterday? And we have to be an investigator. That's our role. That's our responsibility. We have to take ownership of that. Okay? So that's the reasoning behind this no patient. All right. Now, the guy in the ditch, it turned out he was just drunk. But the issue is, it took a CT scan of his head and his neck and lab works in 6 hours in the ER to sort that out. All right. Diagnostics are sometimes difficult, but we still have to go through the process, even though we think it's probably what is the most obvious. We have the burden of proving it's not those other more dangerous things. Yes, sir.
Are lift assists being shifted over to EMS now?
Well,
Because they traditionally, if it comes out as a lift assist only, it goes to fire.
okay. So again, AFD and the other fire departments are under the umbrella of the Office of the Medical Director. Their patient definition will be the same. If they're going and doing a lift assist, then they have the responsibility of offering vital signs evaluation and transport to the hospital. Well, they all right. We're gonna address that. Okay.
They already have the ability to do it.
They do. They have charts.
They may deny
Okay.
it, but they do.
So this is a discussion that we have to have with the fire department to discuss how involved the fire department is going to be in EMS. Okay. If this is going to continue and we're going to develop opportunities to identify those call types that don't need an ambulance, then we need to be able to rely on the fire department to do the refusal in those cases. We have a very talented and expensive piece of equipment that's designed to transport people to the hospital. That doesn't mean we need to send it to every call that requires evaluation or every person that's found along 6th Street that they're not sure if they're sleeping or dead. That should probably be a different resource. Okay, we've got an overutilized resource, EMS, and we've got underutilized resources, and we have to make sure that we're doing a better job at resource matching so that one is not overburdened. Okay? Other questions about that? Right? The ideal situation is that perhaps we send even somebody different to this person. Maybe law enforcement, maybe somebody else.
You're funny.
Sir, can you just clarify on the MBA, 12 people involved?
Yep.
Most of them who would be currently a no patient
Yep.
category.
Not going to change.
Okay.
If they've got a complaint,
Sure.
then they're a patient. If there are no complaint, the typical thing is third-party caller driving by and saw some people on the side of the road. They might be hurt. I want to be Johnny on the spot and call it in. Those aren't patients.
Well, and then the
If-
issue with, I'm sorry. Go
If somebody says, there's a wreck there and I saw some guy at the wreck stumbling around, I'm concerned about him, it's going to be a little bit more of a burden. Okay, again, this is not designed to be overly burdensome. It's designed to set the expectation that if somebody calls and concerned about individual people, that we have the duty to assess and offer. Yes, sir. All right, buses, same thing. Other questions? Am I out of time? They're not listening to me. I'm getting this. Any other questions?